Thanks so much for that welcome. It's a great pleasure to be here today to present on our RESSA, so Rapid Evidence Support System Assessment for Health Policy Making. Our work explores how we can strengthen the evidence support system for health policy making. And it really leads on well from the previous panel's discussions and John Levis's work. John was at the forefront of developing the framework for the RESSA, so it's great to expand further on what he discussed and to put it into the Irish context. Before I go on to describe the work that we did and the findings, I would just like to acknowledge our oversight group that was convened by the Health Research Board. The group included representation from the HRB, the Department of Health, the Department of Further Higher Education, Research, Innovation and Science, and from McMaster Health Forum. So that's Professor John Levis, who we heard from earlier, and a colleague there. And as you know, we come from Evidence Synthesis Ireland and Cochrane Ireland, based at the University of Galway. So just to give a brief outline of the presentation today. First, I'll set the scene, describing what an evidence support system is. What do we mean by evidence, and then what the RESSA framework is. And again, it's going to expand a little bit on what John spoke about earlier. Then I will describe the approach that we took in undertaking the RESSA, our findings, the recommendations, and our conclusion. So first, what is an evidence support system? So an evidence support system provides the structures or frameworks that connect evidence to policy, essentially helping to get good evidence into good decisions. We think about the evidence support system in terms of three parts. So on the left-hand side is the demand side. So this is the evidence users, the policy makers and decision makers who need evidence when they are developing policy or making decisions. On the right-hand side is the supply side, so the evidence producers, the researchers and organisations that produce research. These could be, for example, external agencies or internal units in the Department of Health. And in the middle is the interface, and John Levis spoke about this a lot. It's this connecting role, connecting the evidence supply, the evidence producers, with the evidence users, so the supply side with the demand side. And these, again, we heard about knowledge brokers, evidence intermediaries. These are the people who work in this part. So these three parts of the evidence support system help connect evidence to policy. And the RESSA looks at each of these three parts to see what's working well and where there's room for improvement. And I'll explain the RESSA in a minute, but first just to address what we mean by evidence. And again, you've seen these forms of evidence already. So the Global Evidence Commission, again, which John Levis was a part of, it was established in 2021 as a global initiative to improve how research evidence is generated, shared and used by governments. Promoting stronger evidence support systems worldwide. The Commission describes 8 forms of evidence that can help inform decisions. So data analytics, modelling, evaluation, behavioural research, qualitative research, evidence synthesis, technology assessment and guidelines. So these were all discussed earlier. And the Commission highlights that not all evidence is created equal. Other inputs such as expert opinion, stakeholder views and jurisdictional scans can still play a role, but they should complement, not replace, this more robust, high-quality evidence when decisions are being made. So this slide is a reminder that evidence is diverse, and we've seen that earlier as well. The stronger the form of evidence we can draw on, the better the decisions we can make. When we talk about evidence in terms of the RESSA, this is what we're focusing on. So what's a Rapid Evidence Support System Assessment? So the Global Evidence Commission highlighted that every country needs a strong evidence support system, and importantly, a way to see what's working well in the system and where there's room for improvement. So they developed the RESSA, Rapid Evidence Support System Assessment. And a RESSA looks at the three parts of the evidence support system, which I described a minute ago. So the demand side, so the evidence users or policy makers, is there a culture that values the use of evidence? Is there the capacity and enablers in place to use evidence? On the supply side, the evidence producers, so whether the right evidence is available at the right time for evidence users. And then the interface, connecting the evidence users with the evidence being produced. And the RESSA approach breaks this down into 3 steps. So first, assess what's happening by a structured review of how evidence is produced, shared and used, diagnose strengths and gaps, and then improve by identifying practical actions. So it's a structured framework used internationally to assess evidence systems and provide a roadmap for strengthening them. So what approach did we take? So there is a framework for the RESSA, and we first did a very detailed protocol for how we were going to do the RESSA in Ireland. We followed a structured approach in our RESSA. It involved 2 key stages, a document review and interviews. First, we carried out a targeted document review focusing on documents that could show how evidence is requested, produced and used. So things like strategic frameworks, evaluation reports, committee terms of reference and evidence products. We searched the Department of Health website using predefined keywords and applying clear inclusion criteria to make sure we were capturing the most relevant documents. To ensure transparency in how this was done, we followed PRISMA principles and used the READ approach, ready, extract, analyse and distill, to extract and code data consistently. This allowed us to systematically map the evidence against the demand, supply and interface elements of the support system. Second, we carried out semi-structured interviews with 20 stakeholders across 19 interviews. Interviews were analysed thematically using both the RESSA framework and additional themes that we identified. This was to capture strengths, gaps and opportunities for improvement. We then triangulated the data from the interviews and documents. This involved mapping themes side by side, again across the demand, supply and interface, to check for consistency and to identify gaps and opportunities for strengthening the system. Finally, we sought feedback on our findings from the oversight group and selected senior policy leads. This step helped ensure the analysis was accurate, relevant and grounded in operational realities. We published the RESSA protocol. It's available in HRB Open Research. So our findings. For the documents, we systematically screened 632 documents and extracted data from 50, covering strategies, frameworks, evaluations, committee terms of reference and evidence products published between 2018 and 2024. Most of these came from the Department of Health and key national agencies like HICWA and the HRB. For the interviews, I mentioned we spoke to 20 stakeholders across 19 interviews. This included senior policymakers, evidence producers from national agencies and research organisations such as the HRB, the ESRI, HICWA, Evidence Synthesis Ireland and Cochrane Ireland, and also knowledge brokers working in the interface between research and policy. We also had 3 participants whose roles cut across more than one area, so maybe they were involved in kind of a knowledge broker role, but also producing research evidence. Participants represent a range of seniority levels, including assistant principal officer, and those in senior analytical and research roles. So what do we find? So again, I'm just going to present the findings by the 3 different parts. So the demand side, the evidence users. First, what did we find is working well and what needs attention on the demand side? What came through is the culture and commitment to evidence-informed policy making within the Department of Health. This was reflected in strategic documents such as the Statement of Strategy and the Statement of Research Priorities, both of which set out an ambition to embed research evidence into the policy-making process. Interviewees reinforced this message, describing how there's an expectation that decisions should be evidence-informed. That's probably no surprise based on the discussions we've had earlier, that this is something that is, in most people's head, decisions should be evidence-informed. One person described it as a bedrock. They're very much evidence-driven and analytics-driven because they have to be. In terms of capacity and skills, the department has a dedicated research and development and health analytics division, within which is the Strategic Research and Evaluation Unit and the Research Policy and Innovation Unit. Analytical skills have expanded through staff from IGs, so the Irish Government Economic and Evaluation Service, and also the National Statistical Service, which is managed by the Central Statistics Office. Interviewees highlighted improvements in better access to data, such as the hospital inpatient inquiry data, prescribing data, and also access to tools like dashboards and bite-sized data briefings. So real efforts all the time to improve access to data. There are also helpful structures and processes. For example, in areas like pharmaceuticals and health screening, there are long-established links with the National Centre for Pharmacoeconomics, also with HICWA for health technology assessments, for example, for making decisions around health screening. So overall, there's a clear, strong commitment to using evidence. It's valued and there is an expectation that it will inform policy. But when we looked at how this happens in practice, we found variation. So this is where there's maybe areas that need attention. While there are some areas where evidence is routinely built into planning and advice, in other it depends more on individual initiative or informal relationships. Day-to-day pressures such as responding to parliamentary questions, advancing legislation, briefing ministers, mean short-term demands often override strategic focus. One interviewee observed even finding an hour a week for policy development can be challenging. And I suppose we need to remember this, the issue of time, when we're talking about this, the practical aspects of needing more evidence-informed policy making, but actually time can be an issue. Skills and confidence also vary. While many policymakers know evidence is important, our findings suggest that confidence, skills and resources for sourcing, interpreting and applying evidence vary across policy units. For a policy unit tackling a new question, many feel confused, and this was described by one person as like rabbits in the headlights. So, that idea of where do I go for my evidence, what are my data sources, that kind of thing. That lack of structured guidance means the process can feel ad hoc. There's no formal training requirement to support this. As a result, evidence access often relies on informal networks. People know who to call or where to look, but those systems aren't consistent or sustainable. And finally, there's no formal process for prioritising or tracking evidence needs, so it's easy for duplication or gaps to arise. Strengthening coordination and embedding clearer structures is important to address that. So next, turning to the supply side of the system, and this looks at how evidence is produced. First, the strengths. We found there is the production of a wide range of good quality evidence, data analytics, modelling, evaluations, qualitative research, behavioural studies, health technology assessments and evidence synthesis. So all the different forms of evidence that we described earlier. Agencies like HICWA, the ESRI and the HRB are central. The HRB Evidence Centre, for example, produce evidence synthesis directly linked to the need in the department. For commissioning and coordination, there are structured pathways for some areas. So, for example, the HRB's Evidence for Policy programme allows policy units to submit priority research questions and stay engaged throughout the research life cycle, helping to align timelines and ensure that findings are relevant to the policy question and actionable. We also see this in areas like screening and clinical guideline development, where the National Screening Advisory Committee and the National Clinical Effectiveness Committee have clear processes that ensure evidence is brought in at the right time and in a consistent way. Under technical capacity and infrastructure, I already mentioned there's expanding in-house capability through the Department's Strategic and Research Evaluation Unit, supported by IG's analysts and as well as statisticians, as well as strong national and international partnerships, such as the Hippocrates collaboration with the ESRI and also with the OECD, WHO and European Medicines Agency. But there are still areas that need attention. Quality assurance practices can be uneven. Structured products like health technology assessments apply recognised standards, PRISMA, GRADE, etc. But in some strategy or policy documents, it wasn't always clear how evidence was assessed, which makes it difficult to judge the reliability of what's informing decisions. Evaluation is also not consistently embedded. Interviewees described examples where efforts to include evaluation met resistance, and so the system can't always tell whether policies are delivering on what was intended. For commissioning and coordination, the system is still quite fragmented. Research is often commissioned independently across units without a shared repository or tracking mechanism, leading to duplication in some areas and missed opportunities in others. And finally, in technical capacity and infrastructure, some interviewees pointed out that Ireland's modelling capability is spread across universities and agencies and is mobilised only on an ad hoc basis. And while there have been improvements in access to some data sources, data linkage remains a challenge and access to detailed data sets is often slow. One person described it as it can be difficult to know what data is out there, who owns it and how to get access to it. So in summary, there are strengths on the supply side, there are strong evidence-producing organisations and growing internal capability, but improvements are needed in coordination, quality assurance and evidence production aligned with the timeline of policy making. And finally then, thinking of the evidence support system, the demand supply, the middle part is the interface, so what connects the evidence demand with the evidence supply. Starting with what's working well, we saw examples of structured collaboration, so committees like the National Screening Advisory Committee and the National Implementation and Monitoring Committee for Mental Health create formal pathways that connect evidence to decisions. They bring together clinicians, policy makers and stakeholders to co-develop questions and help ensure the resulting evidence is usable and trusted. The second theme is knowledge brokering, and again we heard a lot about this, so knowledge brokers or evidence intermediaries. We saw evidence of proactive evidence intermediaries or knowledge brokers, both within the department and external. These are people who understand both research and policy, and they can share emerging research even before formal requests are made. This was described as percolating information by one person. So identifying grants, European projects or data sets that might soon be relevant and bringing them to policymakers' attention in advance. And this was a type of anticipatory engagement, helping to ensure that when new issues arise, policymakers already have a sense of where relevant evidence might come from. It's a very practical strength of Ireland's evidence ecosystem. The department has also taken steps to strengthen these connections through initiatives like research and policy conferences, which aim to create more opportunities for policymakers and researchers to connect. Interviewees viewed these as positive and useful, but also noted that one-off events are not enough on their own. The value comes when they lead to more sustained and ongoing collaboration. And of course, informal relationships continue to play a big role. During COVID-19, direct connections between policymakers and evidence producers meant evidence could move quickly into decisions. However, there are also gaps in the interface. So we found that the Department of Health currently lacks a formal interface mechanism. So this means to surface and triage emerging policy questions, match each question to the right mix of evidence forms, and then log, quality assure and integrate outputs into briefings and decisions. So it's really that evidence intermediary role that John was speaking to earlier. The interface currently works mostly because of people rather than process, and there are many points of collaboration and goodwill, but they're not yet joined up through a formal system. As I already mentioned, there is a reliance on personal networks that can be vulnerable to staff turnover, and this can mean needing to rebuild relationships from scratch when people move on or retire or whatever, and that can slow momentum and risk inconsistency. So overall, the interface functions, but it's highly person dependent. There can be good collaboration and goodwill, but it needs a formal interface mechanism to triage policy questions, match them to the right kind of evidence, and track outputs. And finally, thinking about COVID-19 and what we learned during the COVID-19 pandemic about the evidence support system. Some of the documents reviewed and the interviews reflected on the COVID-19 response. The COVID-19 pandemic effectively stress-tested Ireland's evidence support system. It showed what could be achieved when expertise is mobilised quickly and people have a shared common purpose. We saw cross-agency collaboration and data sharing and strong international links with the WHO, the European Medicines Agency, etc., ensuring access to emerging global evidence. The response showed clear strengths, agility, commitment and a willingness to share expertise. It also showed the value of direct engagement between researchers and policymakers during the crisis. Expert advice was often sought immediately rather than through formal commissioning, which made access to evidence faster and more responsive. But it also exposed gaps. Coordination often relied on personal networks and individual initiative rather than established processes. Quality assurance was variable and processes for aligning or documenting evidence activities were not always clear. Much of what worked depended on personal networks rather than formal mechanisms. So the lesson then is to build on what worked, the collaboration, openness and global connections, but to embed it into the system. That means having clear protocols, rapid activation mechanisms and quality assurance structures that can support both emergency and routine policy making. So when we step back from the detail of our findings, the picture that emerges is actually quite encouraging. The evidence support system for health policy making has all the right ingredients, such as strong evidence producers, motivated policymakers and trusted relationships, but they're not yet connected into a single end-to-end system. 3 cross-cutting themes really stand out. First, there is a commitment to using evidence. It's visible in strategy documents and in how people describe their work. The next step is making that commitment in day-to-day processes, so it isn't dependent on individual units or individual initiative. Second, there is production of and access to good quality evidence, but coordination is weak. Without a central place to prioritise, track or share commissioned work, there is a risk of duplication and mixed opportunities. And third, personal networks are a strength. People trust each other and get evidence moving quickly, but the system is vulnerable when those relationships are the primary mechanism. Staff changes can mean having to rebuild connections and momentum from scratch. So our recommendations. So in our report we make 12 recommendations, but I suppose to make them more manageable and presentable as such, we've grouped them into 4 big moves. So first, we need to coordinate and formalise how evidence is requested, produced and shared. We recommend designing and piloting a 2-track prioritisation process, so there is a structured process for deciding what evidence gets produced and when. One track focuses on planned strategic priorities and another for rapid demand-driven requests, supported by a central open access repository to track commissioned work and reduce duplication. Alongside that, we recommend the creation of a standing evidence synthesis hub that can be rapidly activated for health emergencies and maintaining an open catalogue of living reviews to support both routine and crisis evidence needs in prioritised areas. Second, we need to build capacity and culture. The department has a strong commitment to evidence use, but confidence and capability still vary across units. We're proposing training for policy staff and embedding evidence-informed policy-making competencies into performance systems. Also to build evaluation as standards so we learn whether policies work or not, and to strengthen and better coordinate specialist skills, things like analytics, evaluation expertise and modelling through fellowships, secondments and closer academic partnerships. This gives policy teams easier access to the right expertise when they need it without relying on personal networks. We're also proposing piloting rapid forms of evidence, such as rapid evaluations and rapid qualitative inquiry, using predefined templates, minimal data sets, and proportionate governance to complement rapid reviews. Third, we recommend strengthening the interface between researchers and policymakers, and I think this has come up as been really important, this interface part, which is connecting the evidence users with the evidence producers. This includes embedding knowledge brokers within key evidence-producing organisations to translate evidence and quickly match policy questions to the right experts, and have regular research and policy forums with opportunities for shared learning between policymakers and researchers. Finally, ensuring quality and accountability is essential. We recommend developing national quality assurance standards, strengthening data governance, and introducing transparency frameworks to document and monitor how evidence is used in practice. Together, these 4 areas provide a coherent roadmap for a system that's connected, capable, and trusted. And we have a recommended implementation roadmap, which sets a practical phased approach to implementation, starting with actions that can begin straight away while laying the groundwork for longer term system change. So in the first 6 months, the focus is on coordination and getting the foundations in place. So first, to convene an implementation group, establish a central repository for commissioned research, so it's the go-to place to see what's been commissioned previously and what the evidence was and how that evidence was used. Designing the evidence-informed policy-making training model. Between 6 to 12 months, the emphasis shifts to testing and connecting, so piloting a 2-track prioritisation model for evidence requests, defining and trialling knowledge broker roles, and piloting a rapid response evidence service for urgent requests. And in the medium term, 12 to 24 months, we concentrate on embedding what works, so establishing an evidence synthesis hub, embedding knowledge broker roles and quality standards, scaling successful pilots across policy areas. Partnership will be really important to all of this across policy teams in the department, external agencies who produce evidence and the knowledge brokers that connect them so that we can build one coordinated system. So to conclude, Ireland has a strong foundation, committed leadership, skilled people and trusted partnerships already in place, but those strengths are not yet fully connected into a resilient end-to-end system. That's where our recommendations come in. We now have a practical and achievable pathway. Our recommendations taken together would enable faster, fairer and more transparent policy making. And finally, leadership commitment is essential to make this happen. The building blocks are there. The priority now is to connect them and sustain the progress. So just to acknowledge again the Health Research Board's support for this project, the members of the RESSA Oversight Group for their guidance throughout, and to all of the interview participants across the department and the wider system who gave their time and honest reflections. And thank you to everybody today for your engagement and look forward to getting questions later. Thank you very much.